All right, friends. And we are
Right.
recording. So thank you all for being here. Welcome back to this week's academic half day. We have sort of a last minute schedule change for you with some cameos from some recently graduated now PGY4s talking with you today. And to start off, wonderful Dr. Duncan Hussey, recent graduate of our program and now noctensivist in the UW system, is going to be talking to us about hyponatremia. So I will go ahead and let Duncan take it away.
Thanks, Kayla. Yeah. Hey, everyone. Yeah, I just graduated this past June. Miss you all. I'm now at Northwest, been doing some nocturnal ICU stuff. Yeah, I was happy to be back and help with this. I gave this talk, I think, like a couple of months ago in the spring, so apologies to everyone who has heard me talk about this before. But I think hyponatremia is a great topic, and hopefully we can all learn something. And if you have any questions, like, let me know. And if like anyone has any questions about like if you're an R3 and like working on the job application process, like feel free to reach out afterwards. Because yeah, I miss you guys. I'd love to help however. So yeah, I choose this topic, one sec, just because I think hyponatremia is like famously very complicated, and I have this vivid memory of being a MS3 at UW, and my poor R3 at UW was sort of asked to do an impromptu hyponatremia talk, and just like halfway through trying to go through like a volume-based algorithm, we all just kind of stopped and like, yeah, we don't get what's going on here. And he didn't really get what was going on there either. And so you are not alone if this is very complicated. But I promise, like, if you break it down based on ADH and sort of basic principles, it's something that we all can understand. And also hopefully feel confident about managing in the hospital, because this does come up all the time. So the objectives for the talk: we're going to review a framework for an ADH-based algorithm for hyponatremia. We're going to try to understand sort of the ADH-independent forms of hyponatremia, which is primarily tea and toast and beer potomania, both because it is something that we will see and can be a very high-risk form of hyponatremia, and also because the pathophysiology there really sort of underlies the fundamental concepts of solute intake, free water intake, and how the balance can be thrown off. We're going to apply all that physiology to practical SIADH management, because again, this is something that you'll see all the time in the hospital, and hopefully this will be useful. And then we'll also spend a little bit of time sort of identifying and just highlighting the patients who are at very high risk for overcorrection. We can talk about sort of strategies to mitigate that. So yeah, that'll be the plan. So starting just basic symptoms of hyponatremia are these very vague, non-specific things going all the way from kind of fatigue, maybe some nausea, all the way to seizures, obtundation, coma, like all of the terrible things. And really, what this is getting at is that when we are talking about hyponatremia, what we are actually talking about is serum hypotonicity. And that's really all that we care about. And it's that serum hypotonicity. So when the sort of the extracellular space has a low serum tonicity, water is going to flow sort of back into the cells, going to cause cellular swelling. And particularly in the brain, this can lead to symptoms like the seizures, all the scary things. And so sort of the big first lesson, and I would say the thing to take away from this, is we really only care about sodium because it reflects serum tonicity. And there are obviously certain situations where it doesn't. But think of sodium as just a stand-in for serum tonicity. That's sort of a historical and cheaper way. We always get it with the BMP, and it gives us a sense for what the general serum tonicity is. It's not like potassium, where higher low levels can cause arrhythmia. It really is just reflecting the general serum tonicity, and that's why we care about it. So using that sort of like as our basic building block, this is the hyponatremia algorithm that I always go through. It's sort of 3 questions that you can ask for every patient. Each of those questions has a corresponding test. And if you sort of ask these questions, you can have a good understanding of what is driving the patient's free water physiology and their sodium balance. So like we were just talking about, we only care about hyponatremia because it reflects serum tonicity. And so the very first question we should ask in every patient is like, do we care about this sodium value? because we should actually be testing the serum osms and see if we're truly reflecting low serum tonicity. So we always should get a serum osms. And the first sort of category is a lot of the time, a low serum sodium on a BMP doesn't actually reflect low serum tonicity. And the classic one that we see all the time is hyperglycemia. And again, this is like the sodium is truly low in this case. The glucose that's in the extracellular space is pulling out water. It's diluting the sodium, but we don't really care about it because these patients actually behave much more like a hypernatremic patient in that they have a high serum tonicity. They're going to be very thirsty. They're going to be actually trying to dilute their serum tonicity more. And so it's kind of the opposite of what a true hyponatremic patient, true in quotation marks, would be. And then sort of the second one that falls into this category is pseudohyponatremia. And that's when it's like, say, a patient's got a triglyceride level of 1,000 or 2,000, or they have a paraproteinemia, and that actually reflects just an inaccuracy in the way we measure the test itself. When you are sort of like measuring a sodium, you estimate sort of what the non-plasma component of the blood will be, and it's usually estimated about 10%, but if, like, for example, you have a whopping hypertriglyceridemia, that sort of estimate could be off by a fair amount, and so we end up sort of just from pure lab error, sort of miscalculating the sodium. And so those patients, like, they have normal serum tonicity, we don't have to worry about it. But most of the time, we will fall into this category where, like, yes, the patient is hyponatremic, and yes, we do care because they do have a low serum tonicity. And again, a serum osm is sort of less than 285, like, falls into this ballpark. And so then this is where sort of like some algorithms will go different ways. I think traditionally there was sort of a volume-based algorithm that can get sort of convoluted, and I much prefer sort of an ADH-based algorithm because antidiuretic hormone, which again places aquaporin channels in the collecting duct, like, and absorbs free water, like, that is the fundamental hormone that drives hyponatremia and our free water balance. And so if someone is truly hyponatremic, the first question we should, or the second question we should ask is ADH activated? And for that, we test the urine osms, because again, if the kidneys are pulling back free water, they're going to be concentrating the urine. And so if ADH is activated, we would expect a highly concentrated urine. And so there are interesting cases of hyponatremia where actually no, ADH is not being activated, and yet we are still out of free water balance. And those fall, and that's like the primary polydipsia, tea and toast and beer potomania category. And again, this is actually a very important category because these patients are at high risk of overcorrection. So we're going to come back pretty in depth into the pathophysiology here. But again, that is a rare case. And the majority of the time, the patients we see in the hospital are going to have ADH activated. So usually their urine osms are going to be above 200. The cutoff for like what constitutes like activated ADH is a little bit different depending on what algorithm you look at. Sometimes it falls into a very frustratingly sort of middle ground, but in general, sort of 200, I've seen 300 be used. And we can get into more specifics, but it depends on how healthy the kidney is at baseline. Like if you have CKD, you're not going to be able to dilute your urine as much. So a urine osm about like 150, 200 might actually represent the kidney's best attempt at diluting the urine. If you have a loop diuretic on board, this could actually change a little bit, and we'll get into that later. But in general, like a urine osm above 200 or so, I start to think ADH is activated. And then we get to like the fundamental third question, which is this a low perfusion state? And for that, this is why we get like the urine sodium, because really what the urine sodium is getting at is whether or not the RAS system is activated. And we care about this because if this is a true low perfusion state, so ADH is also vasopressin. And so vasopressin is a potent vasoconstrictor. That's why we use it in the ICU. And so if it's a low perfusion state, ADH or vasopressin can be activated not to maintain serum tonicity, which is its primary role, but instead to maintain like effective perfusion and effective blood volume. So if there is a low perfusion state, like ADH could be activated in that setting, and it would be considered an appropriate activation of ADH. But if that's the case, the body's first mechanism for maintaining effective circulating blood volume is the renin-angiotensin-aldosterone system. And so if ADH is activated in a low perfusion state, RAS should be activated too. And so that's why we check the urine sodium, because aldosterone, sort of at the final stage of the nephron as well, is going to be resorbing sodium if the RAS system is activated. And so we would expect a low urine sodium, indicating that the kidneys are really trying to hold on to volume. And so a lot of the patients that we will see, sort of we're at this final stage and we're trying to figure out, is this a low perfusion state? Maybe this is an SIADH state, but starting with the low perfusion states, like these are the ones that we unfortunately see all the time. Classically, this is like where hypovolemia can come in. And then also things like heart failure, cirrhosis, and nephrotic syndrome, even though they are extravascularly volume up, they are still in a low intravascular perfusion state. And so all of these will look identical. And this is also why I really like this algorithm, is because here at sort of this very end point, we can pretty easily tell a patient who is hypovolemic versus a patient who is in florid congestion and heart failure. Whereas oftentimes it is very difficult to like tell between like, oh, is this patient hypovolemic versus euvolemic? And we're really kind of guessing. But we should, and hopefully, yeah, we all can differentiate between the patient who is very dry and a patient who has like 2+ pitting edema, elevated JVP, and has like a fundamentally different etiology for their low perfusion state and corresponding hyponatremia. And then finally, finishing out the algorithm again, there are going to be some situations where ADH is activated, but when we check a urine sodium, the kidneys aren't trying to hold on to sodium, the kidneys aren't trying to hold on to volume. And so this would be kind of a weird, inappropriate activation of ADH that's not tied to the renin-angiotensin-aldosterone system. And so this is where we run into these forms, SIADH being the big bucket. And then classically, we're also taught sort of hypothyroidism can fall into this bucket. It's really interesting. I've tried to do a lot of digging on this. There's like maybe like clearly in like mixed edema coma and like really severe hypothyroidism, like hyponatremia can be one of the sort of one of the symptoms in the constellation of signs and symptoms that develops. But it's very rare that like the presenting and salient feature of hypothyroidism would be an isolated hyponatremia. So you can check a TSH, it's probably not going to be all that useful clinically, but adrenal insufficiency would also fall into this category. And that actually, again, because some of the symptoms of hyponatremia, these nonspecific fatigue, other findings could be consistent with adrenal insufficiency. So I do think it is worthwhile, like checking an AM cortisol and screening for this in most of your hyponatremic patients. And then I think a lot of the frustration with hyponatremia also falls into maybe these borderline urine sodium cases, where it's like maybe the sodium's like 24 or like 18, and you're not sure whether or not like the kidneys are really trying to hold on to volume. And this can also be complicated again by loop diuretics or other diuretics, where we might be peeing off extra sodium because of the effect of the diuretic, and so we're not sure what you can trust. And in these situations, so again, we're trying to oftentimes differentiate between SIADH, which has a million different things that can cause it, versus poor organ perfusion. A lot of the same things that we use to check for like a pre-renal AKI can be effective. And then also, for whatever reason in SIADH, uric acid can be particularly low. So if you're in this, like, yeah, you're stuck, you're not exactly sure if it's SIADH or something else, checking a serum uric acid can be helpful. It will oftentimes be very low in SIADH patients for kind of unclear mechanisms. And then, like we were just talking about, you can also use other markers of poor renal perfusion. So like a FeNA, just like we do for AKI, if they're on diuretics, you can use an FE-urea. And then the BUN to creatinine ratio, just like as a basic one, is also a very useful one to look at. Because again, if we're in a pre-renal state and we're dealing with like a low perfusion state, all those same markers should still apply, and it can paint a very consistent picture one way or the other. Okay, I know that was a lot of talking all at once, so I'm going to pause here and see if anyone has questions about that so far. Yes, Natalia, FeNA will be messed up by diuretics because for example, if we give them a loop, they will be dumping extra sodium, and so it'll look like the kidneys don't care about retaining volume, when in reality they totally could be trying. It's just the loop diuretic is blocking the sodium resorption. So Yeah, and that's why the Fe urea can be a thing. Yeah, yeah, exactly. Yeah. Any other questions about this?
Yeah,
And again,
I'm hoping you
oh,
can comment on one thing here. So when we think about the serum osms greater than 285, but we
yeah.
still have hyponatremia, I've been told before that there still is a risk of seizure, and I'm just wondering, in all of your digging with all of this, if you have found anything about that.
Oh, that is interesting. So, because no, in my digging, I have found that it's so like seizure in hyponatremia is coming from the cerebral edema from the low serum tonicity, and all of the research I've done, and sort of I've listened to many things on hyponatremia, since there's a lot out there. Really, we care about sodium because we care about serum tonicity. And so, for example, someone who's coming in with DKA and they've got a glucose of 600, it is true that their sodium is low because, again, all that extra glucose is pulling out free water into the extracellular space. It's dropping and diluting our other electrolytes, but the tonicity is high, and so you don't have that same risk of seizure, because actually in that case, like with a hypertonic solution, the brain cells will be a little bit shrunken. And similarly, like you can rapidly correct someone's sodium who's in like DKA just by giving them insulin and treating the DKA, and we never worry about like osmotic demyelination syndrome in that setting. So yeah, and I'd be, yeah, send me like where
it was a nephrologist who was telling me this, and I was like,
oh,
yeah.
well, I'd be
John,
very,
does
yeah,
that
I'd
have
be
to
very
do,
curious.
John, does that have to do with the fact that you can get, like a paraproteinemia can give you a serum osms that's greater than 285, and you can have a hyponatremia, but I still think it's like a pseudo hyponatremia. I'm wondering if they're thinking it's coming from somewhere else, because Duncan, I feel like I really agree with your logic on all of it too.
Yeah, and I would say not, yeah, don't claim my lie. This is just what other much smarter people than me.
Yeah, man, I just do what I'm
Yeah.
told.
Yeah.
You're so smart.
Do you think of urine sodium as being a little looser cutoff similar to urine osm in CKD patients? Yes, and also like other things to consider, like for example, if someone has ATN, like any sort of damage to the kidney itself is going to throw off some of these things, because despite like the kidneys trying their best, they aren't able to resorb sodium in the same way. So yeah, that can happen. Actually, it's interesting. I haven't looked up like specifically CKD. I know like in ATN, you can actually get a urine sodium to help differentiate between more of a pre-renal state versus an ATN type picture. But actually, I'll have to do a little bit more digging in CKD if they lose the ability to resorb sodium in the same way. These are great questions. Cool. Okay, I'll give it just another sec here because this is an important algorithm. Let's keep cruising. Okay, so now we're going to take a little segue and we're going to look at again, I mentioned earlier, the ADH independent forms of hyponatremia because they really help sort of, elucidate the underlying pathophysiology of sort of solute to free water balance. So we're going to take a little detour, talk about that, and then we're going to see how it applies to the much more common forms of hyponatremia that we'll see. So again, ADH independent cause of hyponatremia. What's fundamentally happening here is the kidneys are trying to excrete as much free water as they can, but they still can't maintain serum tonicity. And so it all comes down to an insufficient ratio of solute that we're ingesting to free water consumption. And so solutes are anything that the kidneys can use to sort of excrete water. And so common ones are ions, so salt that we take in, potassium, chloride, all of these can be effective solutes for the kidneys. Amino acids, so when we eat proteins, oftentimes that proteins will be broken down to amino acids that we can either pee out or broken down into urea. And then we'll talk about glucose as another sort of one that comes up sometimes, and actually why we can use SGLT2s in SIADH, which we'll talk about a little bit. But those are when we're mentioning like intake of solutes, like those are the things that we really care about. And practically it's like how much are you sort of intaking salt in a regular diet and how much protein do you have in a regular diet. And we're gonna dive a little bit into the weeds here. But so if we think about the typical daily solute load for an average 70 kilogram person, It's about 10 milliosms per kilogram just based on the standard American diet, and you can get a lot of variance here in the diet. But essentially, running through some sort of the average math, 70 kilogram person, they're eating a standard diet where they're getting about 10 milliosms per kg of all of these, like the salt, the protein, all the things that the kidneys can actually use as solute. This is sort of the typical daily solute load that we start at. And then we can sort of apply that daily solute load and see sort of what our range of safe free water intake could be based on the kidney's ability to either dilute or concentrate the urine. And so the kidneys are amazing at its like most dilute urine, like it can get all the way down to 50 milliosms per liter. So that is very, very dilute urine. And then on the flip side, if it is trying to maximally concentrate the urine, it can go all the way to 1200 milliosms per liter. And I've tried to look into like why the kidneys can't dilute it any further. I couldn't really find any great answers. So if anyone happens to know, that would be awesome in the chat. But this is sort of the range that a normal human kidney can either dilute or concentrate. And then just doing some like basic algebra here that I'm including on the bottom, we're just gonna take the solute load, we're gonna divide by the concentration, and that'll give us our free water intake. You can tell over here, for example, if we take our 700 milliosms free total solute load, divide by that maximally dilute concentration, we can safely ingest 14 liters of free water based on like a standard American diet and totally be able to regulate our serum tonicity. And conversely, we can drink as little as like 0.6 liters of water and still be able to maintain our serum tonicity on the other end. So for example, if we ingest more than this, we would start to trend towards hypotonicity. And yes, Natalia, it's a lot to drink in one day. We can still be safe. And then also, like if we're in the desert and we are really trying to concentrate our urine, the kidneys can do a pretty darn remarkable job maintaining that. I know, yeah, Mac, the kidneys are great. The kidneys are great. So this is our range, and some really interesting things can happen. So if we exceed like the 14 liters on a daily period, like this would be primary polydipsia. Lindsay, oh, hi, Lindsay. Lindsay just asked, does water and tea / coffee count? Yes. Primary polydipsia is when we exceed this, and it can either be sort of over a 24-hour period, where some people are just very convinced that they have to drink lots and lots of water, and over time you can eventually end up diluting your serum tonicity if you really drink a lot. Or like the very sad cases are when we sort of blitz the kidneys and we intake too much free water that we can handle in like a shorter time period, because over the course of a whole 24 hours we can consume 14 liters, but I think I was reading like over the course of an hour-long period it's about 2 liters of free water intake that we can handle. And so it's actually fairly easy. Like there were some really sad cases of like water chugging contests on the radio or in like fraternity hazing, where instead of using beer, they used water. And actually you can overwhelm the kidney's ability to dilute your urine in that period, end up with sort of markedly severe hyponatremia, and some of these patients died from seizure and the complications. So that's primary polydipsia, where we had a totally normal like intake of solute. And still we overwhelm the kidney's ability to dilute that. On the flip side, tea and toast and beer potomania, which we'll also see, instead of us overwhelming the kidneys with a normal solute load, in this setting, we're overwhelming the kidneys with an inadequate solute load. And so one of the things to sort of think about here is, again, not all caloric intake, in particular carbohydrate intake, actually leads to functioning solute for the kidneys to work with. And there is a bad joke that like a nephrologist sees a plate of pasta and only sees a cup of water, because if we look at the breakdown of carbohydrates or glucose through cellular respiration, the only thing that we end up with is CO2, which we breathe off, and then water. And so none of that is solute that the kidneys can work with. And so someone can have a diet that is like just things like toast, simple carbohydrates, tea, hence it's called tea and toast, or something like beer potomania, where someone's getting all of their caloric intake from beer, which again has carbs, so they're going to have like adequate caloric intake, but they aren't going to be actually consuming enough solute for the kidneys to work with. And because of that, we can get into issues with free water intake. And so again, all this comes down to, depending on our diet, we can have a lot of variability in how much solute we are giving our kidneys to work with. And to go through the math right here, so again, we just went through, in a standard American diet, we're maybe getting 10 milliosms per kilogram. So if we maximally dilute our urine, we have about 14 liters of free water to work with. Now, in tea and toast or beer potomania, let's say we have a reduced solute load, and now we're only getting 1 milliosm per kg to work with, because we're only drinking beer, or we're really only consuming simple carbohydrates, no salt, no protein in our diet. And then in that setting, if we now apply that same math, the kidneys are still doing the very best they can to dilute the urine all the way down to that 50 milliosms per liter. But if we look at the math now, we can end up with only 1.4 liters of free water that the kidneys can now handle, because again, we just haven't given them enough solute to work with. And it's very easy over the course of a 24-hour period to accidentally intake more than 1.4 liters of free water. Okay, another quick pause here. Natalia, so yeah, like other forms, you can, like hard alcohol, similarly, like alcohol gets broken down. What the hell does it get broken down into? It doesn't get broken down into a solid. I think it's like, what? Yeah, someone smarter than me. But no, yes, it can be like someone can be drinking hard alcohol, be getting plenty of calories from the alcohol, but still not actually be giving their kidneys solute to work with. And then Lily, yeah, that's the other component, is if it is beer, beer also has just a lot of free water with it as well. And so that's why it's, in particular, you can run into trouble with people who are getting their primary form of calories from beer.
Hey, Duncan, I just wanted to share a case that we had that we sort of leveraged this information about like the dilution ability of the kidney. We had somebody who came in with like pretty profound hyponatremia and like I think low to mid one teens. There was a concern for either SIADH or primary polydipsia. And nephrology, like that morning, came in and looked at the urine osms and diagnosed him with primary polydipsia because he had like CKD 4 or 5 and his urine osms were 100. And so somebody with CKD should not be able to like dilute down that much. And so they like literally made the diagnosis based off of that. And it was just, I don't know, you can really tell a lot from, you know, the amount of fluid that people are taking in and what their kidneys should concentrate down to. It's super interesting.
Yeah, kidneys are cool, man. Very cool. That, yeah,
super rad.
Sorry, that's my dog barking. Yeah, and it was a really hard case. We had a case at Harborview, or similarly, a patient came in with like a low sodium. He had some underlying schizophrenia and was just sort of struggling in general. And he had only been drinking orange juice as an outpatient. Like that was, he had it in his head that that's what was the right thing for him to be consuming. And so similarly, he also showed up with a like tea and toast like situation, because the sugar in orange juice, it was giving him plenty of calories, but it wasn't actually breaking it down into any solute that the kidneys could use. Mac, well, yeah, Mac's gonna be a nephrologist. That's awesome. Okay, so oh shoot, sorry, it's been a while since I've given this talk. Where are we going next? We just covered, okay, yeah. So we just covered the ADH independent forms of hyponatremia, sort of reviewed the pathophysiology there. And now we're going to sort of be applying that to SIADH so we can figure out how we can actually treat these patients a little bit more effectively. As you all know, SIADH can be a little bit challenging, but if we sort of remember our ADH-based algorithm, a lot of sort of the fundamental principles can make sense. So just this box here, it's all the things that we just talked about. It's going to be a true hyponatremia. They're usually going to be euvolemic rather than hypovolemic. And then the urine sodium is going to be high. And again, they mentioned normal dietary sodium intake there. Because again, the kidneys aren't worried about volume. They're not trying to resorb more sodium. And so the kidneys don't care about the volume status. RAS is not activated yet. ADH is still on. And then you also notice down here, like these are supporting diagnostic criteria. It's all those things that we talked about that sort of highlight the fact that this is not a pre-renal state, and we don't see any of those poor perfusion markers that we typically see in a hypovolemic patient. And then the other reason that SIADH can be really challenging is there are so many different things that can cause it. Classically, like really be on the lookout for a drug. So SSRIs are classic. A lot of anticonvulsants are classic. Obviously, if you give someone desmopressin, which is ADH, like that can also cause it. But there are a lot of different like drugs and pharmacological issues that can come up. And then again, like ADH is also a vasopressor. And so think of like anything that causes like high levels of stress to the body. So like recently coming out of surgery, nausea, pain, anything that like puts significant stress on the system can also lead to ADH secretion. And so it is a hodgepodge of different things, and part of what makes it so challenging is trying to figure out what exactly is driving SIADH, even if we do diagnose it appropriately. And so going again, we're going to go back to our free water intake, solute intake, to sort of illustrate why SIADH is a problem. Again, still an issue with solute and free water, but now it's the preset urine concentration, not solute intake, that's the issue. So again, going back to our normal solute load, like about 700 milliosms, if we're able to maximally dilute our urine, we end up with 14 liters of free water that we can intake. In SIADH, solute load is still normal, but now the issue is our set urine concentration has changed. ADH is inappropriately activated, and no matter what, the kidneys are going to be set at that new urine concentration of, like, in this case, I just chose 500 milliosms to make the math work out well. So in this situation, normal solute load of that 700 milliosms, but again, we get in the same situation where all of a sudden it's very easy to accidentally take in more free water than our kidneys can handle. And so these patients have to be on a fluid restriction, or it's very easy for them to keep diluting their tonicity. And another quick pause here. Does this, because this is also sort of another fundamental thing. Again, in SIADH, now the variable that's changed is a urine concentration, and that is what makes it very easy to overtake our kidneys' ability to excrete free water. So I'll pause here for any questions, and then we'll use this to sort of see how we can treat it next. Okay, we'll keep going. So one of the things that we can do, it's a good question, Mac. In the setting of SIADH, one of the fundamental things we can do is obviously fluid restriction. If we know they only have 1.4 liters to work with, plus some insensible losses, like we know putting them on a fluid restriction will help at least. But then the other thing that we can do is we can augment their solute load. So for example, let's say instead of taking their diet where they only had 10 milliosms per kg, if we add more protein, we add more salt, now all of a sudden we have 15 milliosms per kg that we have to work with. Now, instead of a like total daily solute load of 700, now just for the math's sake, we have 1050. Even with that set urine concentration, we now have sort of loosened up our fluid restriction, where maybe it's a little bit easier for our patient to be able to handle the sort, because it's very hard to handle a 1.5 liter fluid restriction, but maybe 2 liters is something that's a little bit more doable and sustainable for the kidneys. And so again, here, this is why salt tabs can be helpful. It's not because we are giving the body salt, because hyponatremia is not a salt issue, it's a free water issue. We are giving the body extra solute that they can work with in order to sort of, despite the fixed urine concentration, give them a little bit more wiggle room with their free water intake. And we'll talk about some other products other than salt tabs, which can be useful. I think that's next, yes. So this is a product that I really love. It's soluble urea. I've used it a couple of times in the hospital, and it can be very, very effective. So soluble urea, it's exactly what it is. It's they take urea, they put it into these packets, and you can dissolve it in water and drink it. But it gives the kidneys a pretty massive solute load to work with. And the corresponding like amount of salt tabs that would match sort of one of these packets BID is about 15 grams of salt tabs, which is really hard to take consistently. It like feels awful on your stomach. And also sometimes salt tabs can trigger like a thirst response. So it really doesn't help with the free water intake. But both of these situations, like again, assuming that sort of set urine concentration of 500 milliosms, if a patient takes this urea BID, like that gives them an extra 1 liter of free water. And Kayla, yes, unfortunately, it does taste a little bit like urine because it is soluble urea. They make it lemon lime flavor, which maybe makes things worse. I don't know. But there are, like, I've used it on 2 patients and both of them seem to tolerate it pretty well. Uh, yes, Gabby, it is also yellow, sadly, lemon lime. And yeah, Mac, we will not shame people who like urine. But yeah, this is a way, and again, this is what we are trying to do with salt tabs, is we are just trying to give those poor kidneys a little bit of extra solute to work with so that we can loosen up fluid restrictions. And again, this is a really practical thing that you can do in the hospital because fluid restrictions are very hard, and anything we can do to help patients sort of meet that free water balance is very useful. Okay, any quick questions there before we keep cruising?
Could you talk about, I've also started patients on Urina, but I've never followed these patients outpatient. And as you had mentioned, that some folks are having like a stressful incident in the hospital. And so maybe when they're coming outpatient, their SIADH actually resolves. And I don't know.
Yeah,
Just
no,
curious.
Will, I have not followed people in outpatient, but the nice thing about this is even if we're like, if we're taking in too much solute, like the kidneys can handle that just fine. Because again, they can go all the way up to 1200 milliosmoles per liter. So even if we're giving someone, like, say someone got discharged, they had a more transient cause of SIADH that hopefully starts resolving in the outpatient setting, it's still very safe to be sending patients home on something like soluble urea, because even if we're giving the kidneys like more solute to work with, it takes a lot to swing us all the way to the other end where we would run into issues with us getting too concentrated. That's a really good question. So it's a pretty safe medication to use. One thing, comment for whatever, so it's used a lot in Europe. In the US, it's like classified as a medical food. So it's not covered by insurance. Each little packet is like somewhere between like $1.50 to $2. And so that is also something to consider. It's about like $3 to $4 per day if you want to maintain someone on this. Yes, and Sophie, yeah, that I have also heard that too. I've also heard that just salt tabs like feel like a bomb in your stomach, and like just feels terrible. And so this is like in particular why, again, I haven't used it all that often, but Urina hopefully like helps with some of that. But again, other things that you can do is you can just tell your patients like, hey, like protein intake, because essentially those proteins are going to be broken down into amino acids and urea at the end of the day anyway. And so that's another sort of practical thing that you could be telling your patients to do, and that'll help loosen up their free water restriction. Yeah, you can just have them crush whey protein. That would work. And also salt tabs, another thing to think about, obviously, if the patient has like a predisposition to holding on to too much volume, that's something that you'd also want to be careful about. So sort of summing these up as we get sort of the end here, some practical management tips. Again, there are a million things that can cause SIADH. A lot of them are going to be reversible, but some of them, like medications, you can identify and start to treat. Fluid restriction is, again, the cornerstone because we can augment the solute load, and we can do that with a couple of different things. But at the end of the day, fluid restriction is what's going to help the kidneys sort of help the body not take in too much free water. And then just another sort of practical pearl is sometimes you'll have these patients come in, and actually the CT scan on the right here, this was this really lovely patient. I actually first took care of her at the Harborview MICU, and all of this surrounding her right main stem here is small cell lung cancer, which classically can secrete ADH. And so when she came in, I think her urine osms were around 800. And it was so hard to get it to budge. And we were thinking like, what type of like hypertonic can we give to hopefully help correct her? And if you look down here, just to give you a sort of general sense, like normal saline is about 300 milliosms, 2% hypertonic is about 600, 3% is 900. So she was someone who didn't respond to 2%, had to go to the ICU and get 3%, just so that the tonicity of the fluids that we were giving sort of was above and outpaced the really high set urine concentration that she had from all the extra ADH that was being secreted. And she was a really difficult case because we initially stabilized her with 3% NS. We also gave a couple of pushes of bicarb, like an amp of bicarb, which is 6% sodium in there, because she actually like had seizures. And so we needed to manage that a little bit more urgently. But then transitioning her from that hypertonic to an oral like augmented solute load and free water restriction was really tricky, because unfortunately her extra ADH, like it wasn't a rapidly reversible cause. Like eventually chemotherapy was started and that helped to treat it, but it was a very tricky situation. And Lindsay, her serum sodium when she first came in, I think was like 113. And we're not getting, yeah, I was debating whether or not to have like more stuff on like ICU management, because that's what I love in particular. But like if someone is coming in and she was symptomatic, like she had seizures and that was like a presenting symptom of hyponatremia, the goal to correct is by like 5 to 6 milliequivalents within the first like the first abrupt period to help get out of that dangerous seizure window. And then you still settle into like a 8 to 10 milliequivalent correction over the first 24 hours. So 5 to 6 within the first couple of hours to help get out of the scary symptomatic period, and then still you want to be very careful about correcting long term. Oh no. Okay, this is the one talk I have, but it is, yeah, critical care. I actually have a little bit on it. It's really interesting because you have a lot more tools at your disposal. And then one other like quick thing, and this can actually be useful if you're really struggling with SIADH. 2 other like medications that can help are loop diuretics and SGLT2 inhibitors. Loop diuretics, because they actually wash out the medullary gradient in the kidney, and then SGLT2 inhibitors, because they are miracles for everything. But one of the things when you like pee off extra glucose, it's going to drag more free water with it. And so there's some really interesting emerging studies that like starting in SGLT2 for management of SIADH can cause a meaningful like improvement for them. And then just like very briefly here, why loop diuretics? And again, in hypervolemic patients, loop diuretics are a fantastic way of managing hyponatremia and SIADH, because again, ADH puts aquaporin channels in the collecting duct, but aquaporin channels are only sort of passive resorbers of H2O. And so loop diuretics, by blocking, what is it, the NAK2Cl channel, you remove that really potent gradient. So down here, the medullary concentration is around 1200. If you wash that out, then the aquaporin channels can get placed in the collecting duct, but because it's passive, it won't have nearly the gradient to work with. And so you can actually sort of blunt someone's SIADH with loop diuretics in that way. And that's also why loop diuretics, you have to be a little bit careful about both interpreting the urine sodium, but also the urine osms, because it could be that ADH is very, very activated, but because of the loss of the medullary gradient in the nephron, it's not getting reflected as clearly within the urine osms. And obviously, this is why it's a great option in hypervolemic patients. But you'll see some like people advocate for giving fluids and loop diuretics in euvolemic SIADH patients, which I've never really done because, yeah, it just feels, I avoid fluids in general because I think we can run into problems, but it's something to consider. Okay, and so last thing we're going to quickly go into is who is at highest risk for overcorrection. And so again, we care about overcorrection because of central pontine myelinolysis. This is the scary thing where if someone has been hyponatremic and has had a low serum tonicity for a long time, all those brain cells are going to be swollen at baseline. And then if we rapidly correct it, all of a sudden, all that free water is going to leave the intracellular space. The neurons are going to shrink. And in particular, the myelin sheath is sensitive to this. And so this is where you get that really awful pontine myelinolysis, and you can have really awful neurological outcomes. So identifying like high-risk patients, really it's like the more severe, the higher risk it's going to be. So severe hyponatremia less than 110 is the highest risk. And then to sort of reassure you guys, it's very rare if the initial serum sodium is above 120. And again, all this is a little tricky because these are all based on case reports and it's tough to know exactly, but you can feel a little bit more reassured that if the sodium's starting at greater than 120, it's much less likely for this to happen. And so this is why, for example, that we typically manage patients with a sodium of less than 120 in the ICU. And then chronicity also matters. So for example, like it's a common boards question where someone like seizes in the middle of a marathon, and it's because they've been acutely, like, again, drinking more water than they can handle. Or for example, if it was one of those patients who was on like the water chugging contests, like in those acute settings, the brain hasn't had time, like over time, to adjust, and so that cellular swelling is more transient, and so you are less likely to get the demyelination phenomenon if you sort of acutely got swollen and then acutely get back to a normal tonicity and volume status. And so this is why we think that chronic, severe, and sometimes asymptomatic patients are at the highest risk, because again, or not again, but the thought here is that if you're symptomatic from hyponatremia, you most likely dropped recently into that symptomatic range. And so if someone's coming in and they're seizing, maybe this sort of like, this is a more acute drop in the serum tonicity. And so that's part of why we feel like we have this a little bit more of wiggle room to rapidly correct by 5 to 6 milliequivalents in the short term, and then we still try to go slow after that. And Natalia, yes, we typically think of it as like 48 hours, but the tricky part with all of this is the data is super, the data is not great, because again, this is just a very rare situation. And so this is all based on case reports, and it's tough to really say exactly what puts someone at the highest risk. But we do think of hyponatremia that's acute as less than 48 hours, sort of traditionally. And in that period, it is less likely to get this osmotic demyelination afterwards. So that's why we think chronic, severe hyponatremia are the highest risk people. And then these are additional risk factors that, again, this just comes out in looking at the patients who have had this. Hypokalemia, if they also have that on arrival, if they have a history of alcohol use, you're at higher risk. Cirrhotic patients are at higher risk. And then just general malnutrition seems to predispose patients to having this happen. But again, all of this with a grain of salt, because it is just a very rare phenomenon. And then again, the most important thing that I want you guys to be able to identify is people who are going to be at risk for this are people who have underlying physiology that predisposes them to rapid correction. And so those are going to be ADH independent states, and we'll talk about why in a second. So tea and toast, beer, potomania are at very high risk for overcorrection. And then anything where like the secretion for the stimulus for secretion of ADH can rapidly normalize. So hypovolemia is the one that we're going to see a lot, where as soon as the hypovolemia is taken care of with fluids, then all of a sudden the stimulus for ADH secretion can be turned off, and you can get this rapid free water excretion that we have to be careful of. And then just very briefly, these are the ones that we're going to highlight. And then talking about why this happens in tea and toast and beer potomania is, again, we're at, like, in that situation, ADH is all the way turned off. The kidneys are doing their very best to try and get back to a normal serum tonicity. They just don't have the solute load to do it. But let's say like someone comes in, they get a liter of NS in the ED, like that liter of NS actually has a pretty good solute load. Like that's about 300 milliosms of solute. If you apply that to that same maximally dilute urine, that 300 milliosms will get spit into this maximally dilute 50 milliosms per liter like urine dilution. And then all of a sudden these patients can just dump out free water because the kidneys have finally been given the solute that they needed all along to excrete the free water. And you can see these patients just dump like liters of urine all of a sudden, and you can get a rapid correction. And so this is why, like, the patient that scares me the most is like a beer potomania patient coming into the ICU where they have just been drinking beer, they've had a very low solute intake, the kidneys are doing their very best to get rid of it, and so they are a setup for overcorrecting and overcorrecting very quickly. Questions about that real quick? I know we're almost at time. The other tricky thing about this is, like, oftentimes, like, someone comes in with tea and toast and they're like, oh, maybe they're just like a little hypovolemic. Their sodium corrected when you gave them fluids. You can, it's like a pitfall to then send them home and tell them, oh, you should drink more water because we thought they were hypovolemic, when really more free water intake is just going to be the last thing that these patients need. Okay. And then just very briefly, like, this is just some of the ICU stuff. Like, a sodium less than 120 really should be managed in the ICU. It enables for like really quick sodium checks, close urine output monitoring, which is important in these patients because, again, if we tip into that phase where all of a sudden ADH turns off, the kidneys are going to start dumping free water, and we can see that in a rapid increase in urine output. And then if they're super high risk, I really like using a DDAVP clamp. Like say it's a patient with hyponatremia, came in with a sodium of sort of 110, 111. I'm worried about them overcorrecting as the primary thing that's going to like lead to that devastating neurological outcome. So you can actually give ADH or DDAVP, essentially lock the kidneys in where they are, so not a ton of urine is going to be produced, and then you can use hypertonic saline to just gradually reach the goal that you want over the course of 24 hours, and then you can gradually release the ADH or the DDAVP that you put on afterwards. More historically, D5 has been used. I just feel like DDAVP, I've used it quite a few times now, and it feels very manageable, safe, and it feels like a very controlled system, which is nice. And then another quick pearl is the cat's not entirely out of the bag. Like let's say someone came in, they got too much fluid in the ED, and you check a repeat sodium when they get up to the ICU, and like, whoa, it's gone from 111 to 125. It's still actually worthwhile to like reinstitute a DDAVP clamp or give D5 to try and get them back down. And this is based on rat studies where it seems like it's the average increase over a period of 24 to 48 hours that matters most for central pontine demyelination. But again, we're looking at rat studies, so take everything with that with the, yeah, stop saying grain of salt. Yeah, any questions? Do you have approach to what to do with people's diets during these periods? Oh, yeah, while they are super high risk for overcorrecting, I typically will leave NPO just because I sort of want to be able to manage the free water intake a little bit more closely. And hopefully it's just for that quick period. But yeah, I do let them like have sips, things to like help with the dry mouth. But yeah, it's not a pleasant process, unfortunately. But really we're trying to prevent like the devastating neurological consequences. So I try to explain that as best I can. That's a great question, Celia.
Just was curious about what gradual tapering of DDAVP looks like.
Yeah, it's a great question. Usually I will take like it's usually dosed TID, and then I've actually found that you can I will typically I'll do that for a day, get through that 24 sometimes 36-hour period where I want to be watching that sodium correct, and then as I'm like taking off the DDAVP, I'll usually start a little bit of D5 as like a backup, just like a maintenance infusion rate of D5, and then I'll just trend the sodium, and I will keep trending also the urine output, because again, the first sign that all of a sudden we're getting into this rapid like free water excretion is if the urine output like really picks up. And so one of the ways that you can stay safe is like choose a backup measure like D5, take off the DDAVP, and then just make sure that you're still watching the urine output pretty closely. But it is something like you don't want to manage someone in the ICU for 24 hours on a DDAVP clamp, and it's like, oh great, their sodium went from like 116 to 122, no longer meets floor or like ICU criteria. Like send them to the floor and just stop the DDAVP, because you can still get into trouble there. So it's worth just being like really diligent about those patients. Okay, yeah. If anyone has other questions, let me know. And again, like any questions about, yeah, residency, I don't know, transitioning the next step, feel free to reach out. Miss you guys, and hope you all are doing well.